Okay, good. Oh, that's exciting. Okay, thank you guys so much for joining us on a Thursday at noon for our Learning Health Systems seminar, and to welcome Pamela Peele, who I'm just so excited to have in from the University of Pittsburgh Medical Center Health Plan, or UPMC Health Plan, I have to remember that. Pamela spent 12 years working in the VA before getting her BA from Roanoke College in economics and her Ph.D. from Virginia Tech, also in economics. Prior to becoming the Chief Analytics Officer of UPMC Health Plan, Pamela was actually the Vice Chair of the Department of Health Policy and Management in the Graduate School of Public Health at the University of Pittsburgh, where she was a very successful, independently funded R01 investigator looking at workplace injury, as well as a well sought after collaborator. Since going to UPMC Health Plan, she has not only taken the operations side of a health system by storm, but continued to contribute to the academic side as well. Most recently, leading some work funded by RWJ in optimizing care for medically ill and vulnerable children. So I hope you'll join me in welcoming Pamela today, and hope that you'll find this talk as interesting as I know I will.
Can you hear me now? All right, there's the magic, the on button. All right, that problem solved. Thank you, Rachel, and thank you, Dr. Lee, for inviting me here. It's really a privilege to come. This is a beautiful place. I'm extraordinarily envious that you get up every morning and look out at this gorgeous landscape. But I must say, coming from the East Coast, I woke up this morning and I thought I had turned into a raisin. It is so dry here, it's unbelievable. So I assume that you all invest in stock and lotion or something in order to live in this environment. So what we're going to do today is, I'm going to go pretty quickly through this. I'm going to show you a lot of different ideas. If you have questions, please ask. I'll either answer them or ignore you, but just go ahead and ask either way. So UPMC is a big place. It's an integrated payer provider system. It's the second largest integrated payer provider system in the country, behind Kaiser. It's a distant second behind Kaiser. We have 21 hospitals, and that's all the hospitals we're going to have because the FTC has spoken. We shall not have any more hospitals in Western Pennsylvania. We have a lot of beds, we have cancer centers, we employ a lot of physicians. We are a $12.5 billion a year integrated payer provider system. Over half of that $12.5 billion comes from the insurance side. 10 years ago, the insurance side was budget dust. We weren't even on anybody's radar screen. So the landscape of what we've done as an integrated payer provider system has really changed in bringing up both the insured side and the lives into the system, and then the provider side to service those lives and indeed grow the covered lives underneath this. We on the insurance services side have a multitude of products and things that we stand up. So all of these are products and lines of business. We started out in the insurance world not because we wanted to be an insurer. The CEO of the insurance division was the CEO of our psychiatric hospital. She ran our psychiatric hospital. She's a social worker by training, and she was tired of fighting with the insurance companies over what they would pay for. They would pay for a readmission for a psychiatric patient, but they wouldn't pay for a nurse practitioner to take the patient home on discharge and make sure that the lights were on and the pills were filled, and they wouldn't pay for that. But they would happily pay for the readmission that occurred 3 days later. So she was tired of stupid, silly rules and fighting with insurance companies. She bought an insurance license called Best Insurance, and she went after the procurement of behavioral health care, which the state of Pennsylvania carves out. She won the procurement, so she took over managing behavioral health insurance for most of the Medicaid enrollees in the state of Pennsylvania. And that is how we started as an insurance company. And what happened was, oh Christ, we were an insurance company. We had to do things like adjudicate claims and pay bills and then accredit physicians and do things which we didn't know anything about. So we had to stand up an infrastructure to be an insurance company. Once we stood up an infrastructure to be an insurance company, we were a self-insured employer. Why were we paying somebody to do our third-party billing? So we started being our own TPA. That was the beginning of our commercial business. Then the University of Pittsburgh used us as their TPA, and that was our second commercial client. And we just slowly evolved out into Medicaid and Medicare, children's health insurance. We sell work partners, we sell workers' compensation, absence management, short-term disability, stop-loss insurance. Those are all things we need to do our business. We solve our problem, and then we commercialize the problem. That has always been our model. All right, so let's get into this. Let's think about this for a minute. I'm going to talk just briefly about population health management. Those three words are so misused and so misunderstood in this country, but we all want to do it. Whatever it is, we want to do it. We want to say we're doing it. So what exactly do we mean? Why should we invest in population health management? I'm an economist. Full disclosure, I'm an economist. In this country, we demand that everybody go to school and be educated. We legislate it, we demand it, you must go to school until you are 16 in this country. We pay for that education through state, federal, and local tax dollars. We view it as a quasi-public good. We've been over this for over 100 years. Why do we demand that people in this country go to school? Why are we using taxpayers' dollars to pay for people in this country to go to school? Because we long ago came to the realization that having a literate and educated workforce was good for the economy, and it grew the economy and made a robust economy that floated all boats. And what happens when we take and invest all this money into educating people, but we don't invest in protecting their health? Oh, oops. We forgot to protect our investment. What happens when you are not well enough to take your formal education into the formal workplace when you're 30 years old, or 35 years old, or 40 years old? What happened to the return on investment on our public dollar investment in education to grow this economy? We just degraded our investment. This is why, as a nation, as a country, we should be investing in health capital of the population. We've already invested billions of dollars into educating this population. And speaking of dollars, we're spending now $3.1 trillion a year on health care in this country. If we collectively, look at all the smart people in this room, if we collectively could figure out how to take just 1% of what we spend on health care down, we will have given a gift to our grandchildren. Just 1%. So let's talk about population health. Let's just kind of put it in, again, I'm an economist. I want to get this in a framework so that we can talk about it. So think about this. Let's just call this health, however you want to think about it. This is how much health you can have. And this is time. So over your lifetime. So people are born and they have some level of health, and then this is the maximum for each and every one of us, everybody in the room, that's the maximum amount of health that you can obtain at any given point in time in your life, given your genetic composition and where you are and what's happened to you. So there is a healthy frontier, which is different for each and every one of us, depending on how we are physiologically, psychologically, and environmentally configured. But there is a healthy frontier for us. Now let's talk about health services. This could be anything. We're just putting health services here. Here's health. Now I'm talking about a point in time. Right now, here today, each one of us, how much health can you generate out of consuming health services? Because that's what we sell. Did I mention that? Yes, right. We're providers. We sell health services. Think about it in this way. Think about it as a health transformation function. Each one of us has a health transformation function. If I consume no health services, this is how much health I can have right here, today, right now. And then theoretically, as I consume health services, I can transform those health services, be it nutritional counseling, exercise physiology, whatever it is. I can consume those transform those health services into more health capital for me. And then ostensibly, at some point in time, somewhere after your 28th or 29th CT scan, consuming more health services might actually be degrading your health capital, not increasing your health capital. And we actually did have one woman in 1 year in our health plan who had 28 CT scans in 1 year. 28. And when somebody said, "Ooh, we need to figure out who she is," I said, "Turn off the lights." Then if something happens to you, your health transformation function might change. So you step outside, walk in front of a bus. Ooh, bad idea. So now your initial health capital is very low, and consuming some health services at the emergency room or wherever has a lot of impact on your health, your ability to take those health services and transform them into health. That is the basic concept that I'm going to be working from, that everybody has a healthy frontier over the course of their life. And what we want to do in population health management, you can't be up here. It's not in your feasible set. You can be down here or here or here or here. We want to lift each person up as close to their healthy frontier as we can. That is population health management. It's collectively getting everybody up as close to their healthy frontier as possible. All right, so here's what we're doing. We currently have a provider-driven model. You all know this. And this is how it works. It's fee-for-service. It's high-tech and expensive. It's hospital-based. It's physician-centric. They are highly trained to manage disease with face-to-face patient visits. They are not trained to manage financial risk. These are insurers. This is the beauty of being a payer-provider. Fee-for-service payment, authorization and utilization, benefit structures, negotiated schedules, highly trained. We are highly trained to manage financial risk. We are not trained to manage disease. But what we're doing in this country is we're moving financial risk from insurers who are highly trained in managing financial risk onto providers who are not highly trained in managing financial risk. And we're doing it through ACO models and a variety of things that we call population health management and bundled payments and a variety of other ways. Who wants to volunteer for me to put a stent in them right after this session? Any volunteers for that? I don't actually have any training, but I'm happy to try to see if I can place a stent in you this afternoon. No, I didn't think so. That's the equivalent of asking providers to become actuarially based insurers. And that is what we're doing. So now we're going to have to learn how to do this and learn how to do it together. So this is what we do at UPMC. We're a big provider. We got a lot of members. We got a lot of patients. We have a lot of employees. This is an interesting model. We have 63,000 employees. We're a huge employer. So we have our clinical enterprises, which is our provider system, our hospital system. We have our health plan, and then we have members who are both members of the health plan, so they're covered by the health plan, and they use the services and facilities of the providers that we own and manage. About 48 cents out of every dollar that we spend on health services for UPMC health plan covered members goes to a UPMC provider or facility. 52 cents goes to a non-UPMC provider or facility. So we're not a closed system like Kaiser. That's a beautiful thing. We practice on ourselves. We actually call this the lab. We refer to this as the lab. We practice on ourselves. We learn on ourselves, our members with our providers. We practice. What works, we export out. If we can export it out to non-owned providers and facilities, we just came up with a model that's feasible for the country. Because the country isn't currently populated with a bunch of IDFSs or payer provider systems. And when we do this, I'll show you how in just a second. this is our My Health program. I was talking to someone this morning who had familiarity with this. So this program is published in the American Journal of Preventive Medicine last year. What we did was we wanted to learn how to think about health and wellness among our own employees. We are self-insured. So if we can improve their financial profile and improve their health and wellness, we directly benefit from that. They're our employees and we are self-insured. We are writing the check for whatever medical services that they use. So we started off with, you had to get a biometric screening, you know, blood stuff, statins, glucose, those kind of things. And then you had to fill out a health risk assessment, the single most valuable thing we do. Every year we collect a health risk assessment, and I'll show you some of what we do with it. And then you had to do something in the program. You had to take some healthy steps. We started off with voluntary, please, 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 would you fill out the health risk assessment and go do something? We got about 30% participation because people were trying to be team players. Then we said, we're going to penalize you. No, we're going to penalize you. Yes, that would be the thing. If you don't participate, the first I believe it was $75, $50 or $75 of whatever insurance plan you chose is going to be first dollar coverage for you. I don't care if you chose a closed HMO model, you're going to be at risk for the first $75 or $150 on a family. And we kept upping that amount every year until when we got to, actually the magic tipping point is $250. So when we got to $250 individual, $500 for a family, no matter what you choose, here's an additional first dollar deductible on top of it. We got 93% participation in the program. And we have upped it every year, almost every year. We are currently at $1,000 individual, $2,000 family, first dollar exposure. I don't care what insurance you chose if you don't complete the steps. And the steps are a biometric screening, program participation, which includes a mandatory health risk assessment. And so what we did, and there's out of that 92, 93%, what about the 7-8% who don't participate? They're overwhelmingly physicians. And they are pretty much, they do in fact, many of them incur the cost. So we actually generate revenue off of the deductible that they pay, which pays for administering the program, which is very interesting. So this is a self-sustaining program, as it turns out. And people choose to be completers or non-completers. Okay, so this is the way that we set it up. This is what happened. So this is a measurement of risk. So what happens this is a cohort of individuals. It's 14,128 individuals. The dark bar is where they were in 2007, and the light bar is where they were in 2013. It is a cohort. They are all a year older. So they're getting older, they're not getting younger. These aren't different people. And what happens to their risk over time? High risk, as measured by D. Eddington's risk. High risk goes down, the star means it's statistically significant, moderate risk drops, and low risk increases. People are decreasing their health risk over time participating in the program. All right, this is important. So we started this program back in 2006. In fact, that's how I came to be at the health plan. The health plan hired me as a consultant. I was a academic at the time to come in and model what was going to happen when they tried to roll this out. And by some, even a blind hog can find a peanut every once in a while. By some piece of great luck, I came within about a nickel of what actually happened. But what happens in the first year is cost goes up. You're doing case finding. So I came in and modeled how much case finding I thought we would have, how much money I thought was going to happen to it. Then we started tracking this. So the light bar is actually the Towers-Watson national metric on increases in healthcare expenditures for companies like UPMC. And the blue bar on the bottom is our expenditure experience. So in 2000, we ran it, we started in 2006. In 2007, we anxiously went to see what our results were, and guess what we got? Nothing, exactly. Okay, bear down, go at it. We went at it. 2008, we anxiously wait to see what the results are, and the results are, got nothing. Okay, you know, we didn't have, Rachel was there, however. Bear down by sheer force. We go, 2009, anxiously look at what happened. What happened? Nothing. It wasn't until 2010 that we began to see the payoff behind doing this. And from that, we've stayed behind the national averages ever since. Just in that time frame, that was worth these are our employees. Our employees. That was worth over $111 million to us in savings. But if we had not had the discipline to stay the course, we would not have picked up that savings. But we did, however, pick up something else. These are our employees. They fill out time cards, yes. We have time card data. There are 26 different categories of time off. Who knew? Who knew you needed that many categories of time off? So we looked at unscheduled, and we have PTO, which I believe you do as well. So we looked at unscheduled PTO, unscheduled time away from work. From the beginning, we picked up lost time started going down. This is where we got the first piece of the value out of this program, was people were at work instead of off. And of course, like you, we're a hospital system. When nurses don't show up, oh, oops, bad juju. We have to use temps. Okay, we own our own temp service, of course we do. But still, when you use a temp, you get it's higher cost and lower quality. They don't know the processes. So what we did when we did this, we picked up $3 million just in savings over the top of our absenteeism. And then this is what has happened. The purple lines, purple, that's our logo, okay? So you always know how to orient yourself. The purple line is what's happening to the cost trends for insuring our own employees and their dependents over time. And the blue line is the Mercer national trend. And we are currently year to date at minus 3.1 is our movement from last year. And last year we were at almost minus 7% in our cost trend. Yes?
So you mentioned that you had modeled this before the program went in. Did your model map a lack of savings in the first few years? And do you think that that sort of anticipatory guidance helps people stay the course?
Yes. I would like to think that. Yes, so I did model the lack of. In fact, that was very much what I put on the table. Not only is this not going to save you money, it's going to cost you money. Because there was a lot of case finding when we started screening, and we screened people with a CO monitor as well. So we asked you if you smoked, yes, of course. And if you told us you smoked, we believed that you smoked, but we didn't necessarily believe you when you told us you didn't smoke. So we did a little CO monitor on that, yes. And I do think that that helps set expectations, particularly in year one. This is going to cost us money. Everybody get in the room and nod your heads. We forget our history very quickly. Everybody get in the room and nod our heads. And oh, by the way, we don't anticipate seeing any payoff on this in year two either. Although under the CO monitors was very interesting. We had one woman who swore she didn't smoke, but she had a positive CO monitor. And she swore she didn't live with a smoker, she didn't date smokers, she didn't hang out with smokers, she didn't hang out in smoky bars. She swore she didn't. She was right, she had a leaking furnace. And she had 2 little kids at home, and that's why they were waking up with headaches in the morning, is because they had a leaking furnace. So that was a good story that came out of this. All right, now let's talk about the fun stuff. The data that goes down underneath this. So now we're just going to go through a whole different group of how we use data, think about data, organize data. Oh yes, first we're going to talk about this. Anybody been to Cusco? Cusco, there you go, some Cusco. You'll recognize this undoubtedly. So this is a painting in the cathedral in Cusco, Peru. When the Spaniards conquered the Incas, In Peru, they tore down the Incas' sacred temple. The Incas were very skilled craftsmen and artisans. And then they forced the Incas to build a Catholic cathedral, which is very beautiful. The Incas are very skilled craftsmen and artisans. And then they had them decorate the interior of the cathedral, including with the Last Supper. And you'll notice, my friends, that ain't no turkey on that platter. And so that is a guinea pig, which is highly prized in Peru and actually quite delicious. So this is the point of investing in analytics. Consume something different. If you're not going to consume your big data, your analytics, don't waste your money investing in it. Big data can help you go out of business faster, or it can help you stay in business. It's expensive to invest in, and if you don't stand it up well, you'll just go out of business faster, which might be okay. It's less painful, fewer years of pain. So this is the point of big data. And we have at UPMC, it's expensive. You have to have a robust infrastructure, IT infrastructure to do this. We've invested over the past 6 years $1.8 billion as an enterprise in standing up an extraordinarily complicated IT infrastructure, which is more than we have spent on 3 ballparks in our 3 arenas. And in Pittsburgh is a sports city, trust me. You do not show up on Steelers Friday in anything other than black and gold, or you will go home. So this is a huge amount of money. Now let's talk a little bit about the difference between analytics and reporting, because I think this is important before we get to the fancy stuff. This is a kitchen. Here's the point of analytics. Somebody comes in and says, I'm hungry. I'm hungry. Get some dinner, for Christ's sakes. I'm hungry. Get me some dinner in here. Okay. Don't worry. Here's the problem. The kitchen's a mess. Okay, so let's do something. Oh, great. We got a contractor. We got all this great stuff. We got the kitchen. Whew. Where's dinner? Where's dinner? I'm still hungry. You're still hungry because you have the infrastructure, but you don't have the cook. Analytics is the cook. That's what's going on. You don't need analytics if you don't have a kitchen. Don't invest in analytics if you don't have a kitchen for them to cook in. But this is what you have to do. And here is how we do it. So this is our data, raw data structure underneath. That is housed and governed by IT. All of these data, we have many different data sources. We're greedy little hogs. We take every piece of data we can lay our hands on. Storage is cheap. We take all of that data and we stand it up in a groomed layer that I like to call Spot. And on some of my slides, I actually have a dog and tell people you must adopt Spot and you must do it now. A single point of truth. That's what this groomed layer is. It contains financial information, utilization information, clinical outcome information, lab information, health risk assessment information, marketing data that we buy, external marketing data. We have census data in there. Everything I can lay my hands on, we lift up and groom. So all the individual data is still down here in its granular form. This is all harmonized. So length of stay is down here in a very granular form. You might have to get 3 different data bills to put it together. It's up here already all glued together for you. Don't worry, we have 4 or 5 definitions of diabetes in here because nobody's ever going to agree, and personally I don't care, I'm an economist. So you just tell me what you need and we will lift it up into the groomed layer. What happens when you stand up this groomed layer? Now stay with me, I know you've all been to the meeting. You go to the meeting, there's 3 analysts at the meeting. Somebody says, how many people with blue eyes are there in Salt Lake City? And you get 5 answers. And you spend the rest of the meeting discussing which answer you like the best, right? After the meeting, the 3 analysts go back to their cubes and spend the next 2 weeks trying to prove that they were right and everybody else was wrong. And in reality, nobody was right. This is what you get out of this groomed layer. Your 3 analysts all come down onto the same single point of truth. And if their numbers aren't matching, they either didn't write their query the same, most likely because the time frame was different. But when you're working off a single layer of truth, you're getting inefficiency out of your system. And You're not wasting time paying analysts to go out and do very mundane things of wrestling with data. This took 6 months from the first time to stand it up, 1.5 FTEs in the dark of night. Give up all hope of getting consensus. In the dark of night to stand this up, working with the CMO, because I am an economist, not a clinician, over what the definitions needed to be, and documenting. The documentation took way longer than the coding. And it's all coded in SAS. Once we stood that up, we stood this up, the rules engine. So we have a very powerful rules engine that runs over the top. It's ours. It contains our models. It contains literature information. It contains business requirements. We care about CMS stars because there are billions of dollars attached to improving our star ratings. We track that in our stratification, and we run something called Smart Stars, which uses the knapsack model, if anybody's a mathematician, uses a knapsack model to decide who's going to be outreached to, when, and how. This is all written in SAS. It's our own code. It comes down on this groomed layer and surveils. Oops, there's Susie Sunshine. She submitted she completed an HRA yesterday. That is really valuable information, the HRA. She did an HRA yesterday. She told us she smokes. She wants to talk to a health coach. Bingo. Send her up into, this is ours too, because we couldn't find what we wanted. Send her to a smoking cessation coach. It just electronically sends to the work list in Health Planet to a smoking cessation coach who comes in the morning, sees Susie Sunshine on her work list, mouses over it. It tells her Susie Sunshine wants to quit smoking. She wants a call. And oh, by the way, because it's looking down on the groomed layer, she needs a mammogram and a flu shot. Everybody sees the same thing all the time. People don't see conflicting information. You lose your card, you call the call center. The call center person who's helping you with your card, which by the way is a signal that you're going to use care. Don't need a model for that. The call center can also see you need a mammogram and a flu shot. And can I schedule that for you? Can I help you with that? Everybody's working off the same layer of information and viewing on the same layer. You can send by electronic procurement to mail, so you can drop to mail, you can drop to ELISA or automated voice calls, all electronically off of this. Push it up to Health Planet, which then has, somebody brought me a laser pointer, which then has, which of course I can't figure out how to use, but then has both off-site, on-site. It's just a portal. It's with a view and work content in it. So you could be an off-site nurse, you could be on-site, you can be anywhere. You just log into Health Planet. Health Planet not only contains the information, it contains workflow and processes, assessments and workflow. What should I do now? Fill this out, fill that out. So it has a workflow process in the middle of it. And then on the back side, you can do reporting. You can look at the efficacy of outreach by program, by individual, so that you can see how your care managers, this is meant to be used by care managers primarily, how your care managers are doing. Now, so we have tons of data. One of the first things we did was we decided we were going to do a model to predict who was going to be readmitted to the hospital because, as you know, hospital readmissions are front and center. And we came up with a really pretty model. It works beautifully. It predicts your readmission 30 days in EDRG before your index admission. I don't need to see your index admission. And so before you have ever been, so it predicts your readmission risk if you were to be admitted today. I do not need to see the index admission. And what we did originally was we ran after these people. Oh my God, throw resources at them, let's go, let's go, let's go. And guess what impact we had? That would be right. These are really sick puppies. They're going to come back to the hospital. Let it go. These people, there's so few readmissions down here, it's not economically feasible to throw tons of resources down here. It's not that you can't impact them. It's just that your sensitivity is really low. Here's our little sweet spot. Resources there. And what is the resource? So when you come into one of our hospitals, on the authorization screen, in real estate in the upper right-hand corner, there's your readmission risk. So the intaking nurse can see it, it changes the discharge instruction to a home health visit. By the way, the home health visit needs to happen within 48 hours. So this is how we use this. Then we did that, we took a look at, does it matter to have follow-up post-discharge for medical discharges? This is a little more complicated than it looks. It's not quite as simple. It's a dynamic piece underneath. But the bottom line is no follow-up. Follow-up, yes, it matters, and it has to happen in 5 days. In order for you to get the lift out of this, they need to be seen as an outpatient within 5 days. And so what did our physicians ask? What did we do? We started monitoring our physicians. This is a performance metric for our physicians now. What proportion of your patients do you see within 5 days post-medical discharge? What did our physicians want to know? Would that be 5 business days? And the answer is no, it's not 5 business days. And this is what happened. Here is our 5-day follow-up, and here's our readmission rate. So it actually has had an impact on our readmission rate. So then here's other ways that we use our data. These are the eyeball charts, so let me walk you through what it is. So this is uncomplicated hips and joints, DRG 470. We are masters at fee-for-service. Trust me, if we could have upcoded these, we would have. These are truly uncomplicated hips and joints. So these are by hospital. So the center of the eyeball is the average. These are the confidence intervals. On the metric, this is imaging, consults, testing, and attending. How many images did you get while the patient was in the hospital? How many times did a consult get dropped for somebody to come and see the patient? How many tests did you get while they were in the hospital? And how many times did the attending see the patient while they were in the hospital? And the size of the eyeball is the relative readmission rate for these particular admissions. Now we looked at hospitals. So we're looking across our hospitals at the variation in their performance. And you can see we have a ton of variation. We've had umpteen zillion meetings on what the protocol should be around hips and knees. But the meeting stopped when we did that hospital. They have almost no variation in what they do. They use very few resources, and their readmission rates for these admissions are so small we can barely measure them. And what did the other hospitals say about this hospital's patients? Exactly, they're not as sick, but they would be wrong. Because actually, these are the hospitals that have the not as sick patients. So once we got that, now we were ready to go and do protocol, yes. Yes, they did. And they had a formalized protocol. Literally, you drive up to the front door, they put you on the stretcher, they put the seat belt on, and they push you out the back door on the landing dock, and you're home. Basically, that's what happens. So then we use household data. So we use a lot of two-stage. We're trying to identify people who are going to show up in the emergency room in the urgent clinic, who's going to have unplanned care. We don't know anything else about you but what we can buy in household data. It's a two-stage model. We use this for our exchange members. So health exchange members coming in are risky and dark, what I call very dark to us. We don't know anything about them. The first stage of the model breaks at the age 50. These are the elements that are important. If you're under 50, being female, marital status missing in the data, and no children. If you're over 50, that you are not an arts participant, a computer user, you don't have a military history, you have income below 50,000, and you're 50, and you're female. And then all of these are important. So you're not a tennis player, you don't have grandchildren, you don't play computer games, you don't have cable TV, you don't get cooking magazines, and your zip code. That is what matters in the model. And the model works relatively well. I don't know, I'm just an economist. Yes. We do, but that's the readmission model. We have several readmission models, actually. We also use an in-hospital readmission model that runs in Cerner and updates every 15 minutes with clinical inputs, completely different than our conditional readmission model. And then we have a decision tree model that resolves the conflict when the two models don't agree. So this is 444,000 clinical notes out of electronic medical record. So we just lifted 444,000 clinical notes out of the electronic medical record and threw them at the wall. This is not natural language processing. We just grabbed it and threw it at the wall and said, what words or words live together? And so there are clearly some distinct ways that the words live together. But the first thing we noted was clinicians have a really small vocabulary. They use the same words over and over and over. Sorry, I need to make sure that's not my. Then we said, are there any words or words in here that are signals of the future use of the emergency room? Could we crawl over the top of this data looking for particular text sequences that I don't care with the context, I just care about the text sequence? And the answer is yes. Mother. If mother appears in the electronic medical record, all is well. Future use of unplanned care is very low. I don't know why, I'm just an economist. I don't know why. I actually don't care. It's a very nice signal. WW. If WW appears in the electronic medical record, run from the room with your hair on fire. It is unbelievable how much emergency room unplanned care is coming your way. What is WW? Nope. I had to go ask the clinicians, but of course I couldn't tell them why I was asking, because I told them why I was asking, it might change their behavior when they were entering the clinical notes, and then I'd have to retrain the model, and really I just was too tired to do that. Wheeled walker. And it's not that you have a wheeled walker. I already know that. We paid for it, remember? I know you have a wheeled walker. It's not that you have a wheeled walker. It's that the clinician chose to call it out in the clinical note. That's the signal. The clinician chose to comment on the wheeled walker. That is the signal. Oh, by the way, SW, social worker, is another very big. The clinician writes SW, things are not going well. Welcome to Southwest Pennsylvania. This is a model of attraction and repulsion. This is open source software called Gelfi, so you just download it. It handles Giganda data files. So in this particular model, here we go, all the pink dots are facilities. They're hospitals, they're skilled nursing facilities, they're dialysis clinics, they're some kind of a facility type charge. All the blue dots are specialists. We have a lot of specialists. If you need some, please let me know. We ship overnight dry ice. Guaranteed live arrival. And then all the dark dots are primary care physicians. Here's what's happening. If the facility and the specialists and the primary care physicians exchange the same patients, that is, the patients move around among the same providers and facilities, those providers and facilities pull together. They attract to themselves. If they don't, they push apart, they repel. And so we have a big academic medical center, it's up in here, and you can see most of our stuff is somehow slopping all around in here. Cleveland Clinic is right there. So it's all flopping around in here. Ooh, look at that. Pretty big nexus of providers and facilities. Tight, 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 tight. Meaning that they exchange among themselves, they attract, they exchange. Highly repelled from everybody else. Highly repelled. What's going on there? What is that? Children's pediatrics. Children's Hospital, Pediatric Services, Pediatric Subservices, Children's Rehab, and notice these ghost trails. Those are patients moving between the nexuses. And what you'll notice is there's a figure 8 on it. That means there's something there. What is it that's there? City of Pittsburgh EMS. So when patients move between this big academic place and the Children's Hospital and providers, overwhelmingly it's in medical transport. On the top, you'll see this little group up here. Number of facilities, providers, specialists, tight, 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 tight. They share among themselves, they're tight. They don't share with other people, they're repelled. And again, It's medical transport that changes them. This is Heritage Valley Health System. It's not a UPMC-owned system. It's its own system. They run their own rehab, LTAC, nursing, PT, everything. They are clearly a very self-contained system, hospital and system. Okay. Now take away the facilities and just leave the doctors. There are 30 natural clusters of physicians in Southwest Pennsylvania. So each one of these, same idea, same model, each one of these pictures is a cluster of physicians. Each doc is a physician. When they cluster together, that means they exchange the same patients and they attract. And when they push apart, they're repellent. So what we do with this, so let's take this little group up here. And we can turn on and off the doctors by their percent of line of business. So if I wanted to look at physicians who see a lot of Medicaid business, I could just hold it to Medicaid people. And so then I've color-coded it to make it simple. So when the yellow group, a patient leaves them, they overwhelmingly come down onto that red group. And when patients leave the red group, they overwhelmingly go back up to the yellow group. But they don't go anywhere else, whereas down here, this group is sharing with a lot of people. If you were going to have a narrow network and you were going to take the yellow folks out of your network, you just made a dysfunctional network because the red folks have no place to send their patients. And then this is a hospital view. Each dot is a physician. There are 3 different hospitals in play here. Again, attraction and repulsion. What you see is doctors who use this hospital, Hospital A, they all exchange patients with each other. And they make a fairly good cluster up here. And when their patients leave them, the few that do, they come down onto Hospital B. Hospital B has 2 distinct clusters of physicians. These physicians all exchange with each other, and these physicians, but they don't exchange with each other between these 2 cliques of physicians. And then when they lose patients, sometimes the patients go here, this group sends patients up here, and this group overwhelmingly sends patients down to Hospital C, and Hospital C is not much of a sharer with anybody, by the way. These 2 groups would migrate completely apart. This group would come up and live by Hospital A as far as how tightly they share if it were not for 3 doctors in the center there. Who are those 3 doctors? The only 3 radiologists in the county. So again, you use your data to see. You could never see this if all you had was a stack of number 3 font tables. You could never in a million years figure this out. You have to see your data. And if you can't see your risk, you can't manage your risk. And as financial risk comes down on top of providers, you have to be able to see the risk that you're sitting on. Which brings me to this. So we have made, am I doing on time? Perfect. So this is our newest inclination. We take each member, each patient, and we map them latitude and longitude to the place that they live. And if multiple people live at the same place, we just map multiple people to the same place. We make each person as tall as their stack of chronic conditions. So if you have no chronic conditions, you're ground level. If you have 3 chronic conditions, out of the 31 chronic conditions that, I don't know, ask our CMO, we got from whatever, some defensible place. We took out hypertension because it's just so prevalent, and we took out high cholesterol. You are as tall as your stack of chronic conditions. All right, now put everybody on a map, right? Put them where they live. Now I'm asking the data to break the map into regions that make sense from the relative density of chronic illness. And there are 12 natural regions. Pittsburgh is right up here in this region. Here we go. This is our population density. So the bulk of our enrollment population is right up here in Pittsburgh, in this area, not here or here or here. So you can see we have less than 50,000 covered lives up here, but we have a lot of covered lives in Pittsburgh. So I just orient you that the density is distributed like this. Disease is distributed like this. So what we've done is we come in here and make these hot spots, and I'll show you a couple of ways of thinking about it. Here's Pittsburgh. This is where the bulk of our members live. But this is where the relative density of chronic disease sits. Again, everybody is as tall as their stack, and then you have to use a smoother on this. We use a kernel density estimator because people are all different, they're all jagged, and you want to smooth the mountains and the hills. So you just use a kernel estimator is a very effective way to get at that. So this is a way of looking at our map of chronic disease. I can show it to you in a topography way that is slightly different. Again, same concept, just a different way of visualizing it. So you think about it, this as an MRI. And I'm giving you, this wouldn't be a sagittal plane, but whatever that would be in an MRI. So here are the hilltops that we've been looking at. Here's what's underneath. Here's what's interesting. Look at this tight upward pike. So I've got a tall peak. Remember, you're as tall as your stack of chronic diseases, but I have a very narrow base. So I've got a lot of tall people in a small area, but I don't have very many moderate height people or low people sitting in this area. Whereas somewhere like over here, I've got a big base going on underneath. So this is a way of visualizing, and remember, population health management is not about managing trauma. It's about managing chronic disease. So if we're going to do population health management, we have to understand how chronic disease is distributed over the area that we're trying to serve. Here is you can look at these things a zillion different ways. The same concept, but what I wanted to point out is, here's how it varies. So this particular hotspot, which is southwest of Meadville, Pennsylvania. So if you're in Pennsylvania, please make sure you drive away from this, not towards it. Has twice the cancer treatment prevalence of all of our other areas. There used to be a lot of lead plating and heavy metal in this region. There no longer is. This Star City Junction. It is the epicenter of disease. Please avoid it. They have twice the diabetes. They look about the same. Where's my cancer? So they have a little more cancer, but they look about the same on other things, but they are really diabetes, diabetes, diabetes. So even within a narrow map, and these relative densities of chronic disease, which is what we're trying to manage in population health management, there is variation. So we deploy boots on the ground and do regional management. And the teams vary by the region because the disease burden varies by the region. This is the money. So these are our hotspots. They're a little hard to see. The darker the area is, the more expensive they are. So the money lies right over the hotspots. This is Star City Junction. Here it is, right there. And again, you can see the hot spots and the money. So there is a reason to go and manage where you have density of chronic disease because that's where the money is being spent. And you can't save money if people aren't spending money. You have to spend money to save money. I tell my husband that all the time. He's having a hard time with the concept. But if you have patients who aren't spending any money, you can't save any money on them. Then use the same visualization technique. This is where our facilities are. So if the facility is purple, it belongs to us. If it's not our facility. Look where we concentrate our resources. This is Region 5. We don't have any facilities in this region. I like to call it Sector 5. We don't have any facilities in this region. These are our primary care physicians that are employed by UPMC. We have a few of them down here, but look where we deploy the bulk of our primary care physicians, and we don't have any up here at all. They probably have more veterinarians up there. I think the deer population is higher than the people population, but we don't have a single employed primary care physician in that area. So how are we going to manage chronic disease? We have a hot spot right down here. We don't have a facility, and we don't have any employed physicians in that area. Now it's a contracting issue of who we're contracting with and how we're contracting with them. These are primary care physicians that don't belong to us down here and up here. This is driving contract strategy behind how we should be contracting and gain sharing with physicians. And then this, of course, I'll leave you with, which is the danger of big data, besides the fact that you can go out of business faster, is that here's what happens. I need this, I need that, I need something. I need a report on this, I need a report on that. And pretty soon, your analytics people are throwing dots of information at you. And the more you ask for something, the more dots of information they are throwing at you. And here come more dots of information. And here's an email with 7 files included in it. And here's more dots of information. And pretty soon, this is our response to that. And that is not worth an investment in analytics. Then I'll leave you with Herb Syne, Nobel laureate in economics, who said this in 1971. An information-rich environment creates a scarcity of what it consumes. Think about that. An information-rich environment creates a scarcity of what it consumes. What does information consume? Your attention. Exactly. So the job of a good analytics shop is to make their output attention-worthy by weaving it into the story of what needs to be understood in order to manage the organization through this transition from fee-for-service to value-based care and financial risk. Thank you. We have a couple minute questions, comments, answers? Answers, yeah, answers would be good.
Great presentation. I really love all this slide and all this information. I have a question. The models that you use for network analysis, so what kind of validation have you done to validate?
So we build our models in the normal way that you would expect. We have a holdout set. And so we build our models on our development set, and then we test our models on the validation set. Then after we often have to retrain our models. The world is changing. So then we come back and retrospectively look back at how we know how well the model works from the validation set. We know the sensitivity and specificity. But then we come back and look at not only how much did we get right, the important factor for us is how much did we miss. So specificity is the key. It's not sensitivity. Most model builders go after sensitivity at the expense of specificity. Specificity is how many times you were wrong. You identified somebody as being a target, but you were in fact wrong. The reason that is so important in this kind of modeling is that the resources are intense and expensive. You're sending a team to somebody's home, boy, you better be right about which home you're sending the team to. So we do it retrospectively, and then sometimes we discover we have to go back and retrain the model.
So we go forward in the future to
Yes.
test that.
And we go backwards. We go forward and backwards on our testing. Yes?
How do you engage physicians to effectively use the data that you have, especially the health risk assessment?
Gain share. Oh, and I don't think I have tons of slides. We had to kind of whinny it down. So the health risk assessment, which we use. So there are, on our Medicare Advantage enrollees, the health risk assessment we've been using, which I think we made up, has 26 questions on it. There are 8 combinations of the answers to 5 questions. That's all you need. Those people will be 300% more expensive in the coming 12 months than everybody else. So we feed this information to our physicians through gain shares. So we put them at a financial upside only, at a financial gain. After they've been in the gain share for 4 years or so, we move them to downside risk. So that's how we get and they are so focused on these data because they don't even know that Susie Snowflake is their member. They don't even know she's in their panel, and they're at financial accountability for her. They really focus on the data.
How much effort are you putting in uncertainty quantification of these models? I think that right now the healthcare system is so inefficient that picking up targets of intervention is fairly straightforward. As you start cleaning up the big bottleneck, you will have a lot of targets that will be of similar probability. How you deal with uncertainty quantification in this very complex model?
Yeah, so that's a good question. And part of it is the world is changing very quickly, particularly around both how we code and understand it. Most of these models are working off of Medipack data or billing data. They are dependent at their core in how the clinician codes. And people code differently depending on where they are and what they do, and how much they code depression and mental illness and things of that nature. So this requires us to retrain our models.
But are you using like Monte Carlo techniques?
Oh, yes,
to
yes,
that kind
yes,
of
yes,
stuff
yes,
to
yes.
get confidence in
Yes,
the person, stuff
yes,
like that?
absolutely. Other questions? We're right at time. Last question. You get to have the last question.
Oh.
Congratulations.
So
We'll give you lunch for that.
I got it ready to go. So I'm from Australia, and most of our medical care comes obviously through the government socialised medical system. And UPMC looks like you're kind of expanding and trying to share your techniques internationally. Do you know of any sort of socialised medical systems that are benefiting from using big data in a similar way?
The Canadian system uses big data and very much in this way. So I have a couple of colleagues in Canada that are using similar techniques. The mountains of disease, as I like to call it, that seems to be unique to us. We seem to be the first ones to have come up with that technique. But once we come up with things, we're happy to share and socialize, and because the more standardization there is about the way we think about this, the more benchmarking that is available for us to understand what we're doing. Okay, we're at time. Thank you very much. You've been a great audience.